Today we are going to talk about 2025 guidelines of prevention, detection, evaluation, and management of high blood pressure in adults. This guideline published in a couple of weeks ago in Circulation, Heart Association journals, Circulation, so on and so forth. Before we embark upon the guideline as such, we wanted to make sure there are certain nomenclature they have used in the recommendation. When it is number one, when it is very strong recommendation, it comes as class 1. That means it's recommended, is indicated, useful, effective, beneficial, so on and so forth. It also color coded as green. Class 2 recommendations again divided into two categories. Class 2A, that is moderate, that means the recommendation is reasonable, can be useful, effective, beneficial. Class 2B is a weak recommendations, may or might be reasonable, may or might be considered. Class 3, there is no benefit. Generally, those are level of evidence is A or B use only. It's not recommended, not indicated, useful, effective, or beneficial. Class 3, outright harm, potentially harmful, causes harm. So this is the nomenclature they have used during the entire recommendation. And the level of evidence. When the level of evidence is A, that means the high quality evidence from more than one randomized control trial, meta-analysis of high quality randomized control trials. The randomized control trial, they have divided into two groups, high quality and also moderate quality. Level A means high quality. Level B again divided into two. One is randomized and non-randomized. And level C is limited data. Level C or expert opinion. Only three, A, B, C. B, two groups, randomized, non-randomized, and C, limited data and expert opinion. There are certain great information available in this one. This particular part 1 talk, we are going to talk about how to evaluate blood pressure, how to take blood pressure, and we will go all the way to secondary hypertension and prevention. The medical management we will do in part 2, planning to do even that one into two parts because the total number of pages is 105. So it's kind of hard to do everything in one seminar. Number one, definition of high blood pressure. The class of recommendation is 1, it's non-randomized. In adults, BP is categorized as normal, elevated, stage 1, or stage 2. What does that mean? Blood pressure normal means the systolic blood pressure is less than 120, diastolic is less than 80. Elevated, systolic blood pressure is 120 to 129, diastolic still remains less than 80. Stage 1 hypertension, systolic 130 to 139, diastolic 80 to 89. Stage 2, systolic is more than 140, diastolic is more than 90. Blood pressure indicates blood pressure based on the average of careful readings obtained more than 2 occasions. This table also excludes individuals who are pregnant. Elevated BP and hypertension are associated with higher risk of cardiovascular disease, end-stage kidney disease, subclinical atherosclerosis, and all-cause death. Hypertension is the most prevalent modifiable cardiovascular disease risk factor and is the leading cause of death and disability worldwide. From 2017 to 2020, prevalence of hypertension defined as BP more than 130 over 80 or receiving anti-hypertensive therapy among adults in the US was 46.7%. That means almost half of the population is receiving or having a high blood pressure. With aging, systolic blood pressure levels tend to rise steadily to the end of life, whereas diastolic blood pressure levels rise until the fifth decade of life, then plateau for a decade and decline thereafter. The current rates of awareness, treatment, and control of hypertension remain far below the target levels for all age groups. As you can see in men, overall, you can see the awareness is only 60%. Control of blood pressure less than 140 over 90 is around 65%. Only less than 50% receives treatment, and the control of blood pressure less than 130 over 80, only 20%. That means 80% of the patients do not have a control overall. This you see in different racial groups and also different age groups. The same trend continues. In women, the story is same. The control, absolute control, is about 20%. Awareness at the max is 60%. So that has made a little bit difference among the racial groups, but it is not robustically different from one from another. So what are the prevalence of hypertension in United States, adults 18 to 80 years? As you can see, the high blood pressure is higher when you reach 30, even in 80s, 29, it's 20%. That means one-fifth of the population have high blood pressure. When you go above 30, that incidence goes much higher to the level of half and more than three-quarter when you age 75 to 80. And there is little difference in the racial groups. The best performing is whites, non-Hispanic whites, and the worst performing is non-Hispanic blacks. This is across the world, the global percentage of raised blood pressure. It's again, not many developing countries have an accurate information on the blood pressure. Based on the available data, these are all we see. In fact, the better blood pressure awareness and control is in developed countries than third world countries or developing countries. This is the data in women. Women is worse. So cardiovascular disease is common or more common in women than in men. Hypertension frequently co-occurs with other cardiovascular risk factors. 16.6% are smokers. 72.6% are overweight or obese. 12.3% diabetes, 13.4% diagnosed to have chronic kidney disease. So these are all modifiable risk factors for hypertension. So one has to quit smoking and reduce the weight and identify and treat diabetes or prevent diabetes. And the same thing is true for chronic kidney disease. The relative risk for cardiovascular disease associated with blood pressure attenuates somewhat, but absolute cardiovascular disease rates are substantially higher at older compared with younger age. So the treatment of hypertension is very essential, and older the individual, we need to be so meticulous in controlling the blood pressure. Once blood pressure is above normal, meaning more than 120 over 80, there may be irreversible vascular damage and residual risk, even if antihypertensive treatment is started. This is a very important message to bring about from early childhood onwards, because even when the age is 18 to 29, the incidence of hypertension is almost 20%. That is one-fifth of the population. So identifying not even identifying, preventing hypertension prevents vascular damage and residual risk. The second point is very important. Individuals with the diagnosis of hypertension who have treated So 100, less than 120 over 80 have twice the risk of cardiovascular disease of adults without hypertension who have untreated blood pressure of less than 120 over 80. It highlights the importance of primordial prevention of BP elevation. So even if you treat the blood pressure, bring down below 120 over 80, the fact is you had hypertension itself increases the risk to the extent twice the risk, that means 100%, than untreated systolic blood pressure, diastolic blood pressure less than 120. So prevention is the best way to um, control or deal with high blood pressure. Okay, once we have diagnosed, once we have hypertension, how to deal with them. Number one in hypertension is, or high blood pressure, accurate measurement of in-office blood pressure. The class of recommendation one, that means the number one recommendation based on limited data. When diagnosing and managing high blood pressure in adults, the standardized methods are recommended for the accurate measurement and documentation of in-office blood pressure. When measuring in-office blood pressure in adults, it is reasonable to use oscillometric method with an automated device over the auscultatory method. Most of the offices in United States, they do not use auscultatory method because of the usage of mercury in auscultatory method. So what are the important steps in office blood pressure measurement? So number one, the patient should avoid caffeine, exercise, and smoking for at least 30 minutes before measurement. Ensure the patient has emptied their bladder. Number two, use a blood pressure device that has been validated for accuracy. Number three, use the correct cuff size on a bare arm. Don't put above the clothes. Number four, the patient's arm should be supported at higher level. Number five, have the patient relax, sitting in a chair, feet on floor, legs uncrossed, and back supported for more than 5 minutes of rest. Then only you check blood pressure. Neither the patient nor the clinician should talk during the rest period or during the measurement. The patient should not be using their phone. Blood pressure measurement should be taken in a temperature controlled room. It should not be too cold or too hot. Take two or more blood pressure measurements at least 1 minute apart. Average the readings and provide the patient their blood pressure readings both verbally and in writing. The accurate measurement of BP is essential to diagnose high BP, ascertain BP related CVD risk, and assess response to therapy. Use of BPD device validated against a reference standard with an appropriately sized cuff is paramount for accurate measurement of BP. Single reading is inadequate for clinical decision making. Very important point. Office BP should be based on average of available readings and an average of more than 2 BP measurements obtained on more than 2 separate occasions may minimize error and provide more accurate estimation of office blood pressure. Clinicians and staff should have initial and ongoing training, including competency checks, ideally every 6 to 12 months. It is better to kind of look or be in the office or be doing the stuff we're supposed to do. When a new diagnosis of hypertension is suspected or confirmed, a comprehensive medical history, physical examination, lab tests, and other diagnostic procedures should be performed. The primary goal of this evaluation is to inform the need for optimal choice of GDMT, meaning guideline directed medical therapy for BP lowering. Evaluation is useful for the identification of contributing causes of elevated blood pressure, including secondary causes, estimation of predicted cardiovascular risk, and evaluation for the presence and extent of target organ damage. That means impaired kidney function, albuminuria. Basic lab testing should be repeated at least annually or sooner. Optional testing. Some patients may need a little bit more than the regular testing, which are cardio biomarkers, high sensitivity troponin, B type net peptide, echocardiography, coronary artery calcium. Additional diagnostic evaluation should be considered when secondary causes of hypertension are suspected. So, what are the diagnostics tests recommended according to this guideline? Complete blood count, serum electrolytes, which is sodium, potassium, and calcium, serum creatinine with the estimation of glomerular filtration rate, lipid profile, fasting blood glucose or hemoglobin A1C, thyroid stimulating hormone, urine analysis, urine albumin to creatinine ratio, urine protein to creatinine ratio, and EKG 12 lead. What are the recommendations for lab tests and other diagnostic procedures? They strongly recommend class 1. It's based on expert opinion. As you mentioned, it's recommended strongly to get this lab test during evaluation of hypertension. There are two terms we are going to discuss. One is ABPM or HBPM, meaning ambulatory blood pressure monitoring and home BP monitoring. What is ambulatory BP monitoring? It involves wearing a fully automated device, usually over a period of 24 hours. Readings obtained at relatively frequent intervals during the time, 15 to 30 minutes, and less frequent intervals at night time, 30 to 60 minutes. It automatically checks and records. What are the advantages of ambulatory BP monitoring? Number one, it provides estimates of mean BP over the entire morning period and separately during daytime and nighttime. Determine the daytime to nighttime BP ratio to identify the extent of nocturnal dipping, which usually happens and abolished in patients with obstructive sleep apnea. Identify the early morning BP surge pattern. Estimate BP variability. Allow for recognition of hypertension. Home blood pressure monitoring. It involves a patient measuring their BP at home using an oscillometric device over days to weeks. It provides estimates of mean BP over the entire period and separately during daytime and evening. Determine daytime to evening BP variability or BP variability across days. The recommendation for ambulatory BP monitoring and home BP monitoring are as follows. The recommendations are level 1 and with a strong evidence. Level A evidence, that is the highest level of evidence you can have. In adults with suspected hypertension, out-of-office BP measurement by either ambulatory BP monitoring or home BP monitoring are recommended to confirm the diagnosis of hypertension. In adults who are taking antihypertensive medication, the home BP monitoring is recommended for monitoring the titration of BP lowering medications along with co-interventions such as patient education, telehealth counseling, and clinical intervention. These 2025 guidelines do not recommend using cuffless BP devices. Even though they are coming up, the reliability is still not proven. It may get proven because as the day passes or as the year passes, the technology is improving. Just next guideline might change. So how to do home blood pressure monitoring? Device and blood pressure cuff. Use a blood pressure device that has been validated for accuracy. Check with your clinician or other members of your care team. and the following website for devices like validatebp.org. Use a correct cuff size matched to the size of your arm. Avoid smoking, caffeinated beverages, or exercise within 30 minutes before blood pressure measurement. Place the cuff on a bare arm, and your arm should be supported at heart level. The bottom of the cuff should be placed directly above the bend of elbow. You should relax and sit in a chair, feet on floor, legs uncrossed, and back supported for at least 5 minutes. While relaxing and measuring your blood pressure, please do not talk, use your phone, or watch TV. You should take two readings, 1 minute apart, twice a day, for a total of four readings. Two readings in the morning after emptying your bladder and before taking your medication and eating, and two readings at bedtime before sleep. Check blood pressure for 3 days. That's minimum to 7 days preferred before your appointment or interaction with your clinician. Document your daily blood pressure measurements in writing or electronically. Share your readings with the clinician taking care of you. So these are all very important, the accurate measurement of blood pressure so that you can rely on those numbers. Patient diagnosis. Always evaluate. Your patient with hypertension need to be evaluated for dietary intake factors and also non-dietary factors. The dietary intake factors are higher sodium intake, lower potassium intake, lower calcium and magnesium intake, lower diet quality, lower intake of fruits, vegetables, plant proteins, and fiber, and alcohol intake. All needs to be considered when you are evaluating patient with hypertension. Non-dietary factors are genetic variants, overweight and obesity, lower physical activity and fitness, sleep disturbances related to duration, quality, regularity, and or disorder breathing, psychosocial stressors, and air pollution. All these can play in the causation of hypertension. The BP category is based on the office and out of office BP measurement. We are going to focus on white coat hypertension and masked hypertension. Again, it's grouped into two among individuals not taking antihypertensive medications and those who are taking antihypertensive medications. When you take blood pressure in the office setting and blood pressure outside the office setting, there is no difference when you have normal blood pressure. When you have a sustained hypertension, it is present in both the places. Okay, here is the deal. When you have masked hypertension is diagnosed, there is no blood pressure in the office setting, but there is apparent high blood pressure when you do it at home. It's a non-office setting. White coat hypertension is defined, you have hypertension in the office but not at home. The same trend you see in those patients who are taking antihypertensive medications. The controlled hypertension, that means controlled hypertension, there is no difference between office and outside office. Uncontrolled hypertension, there is high blood pressure in both the places. Masked uncontrolled hypertension, you see, there was no high blood pressure in the office, but it is apparent high blood pressure in the non-office setting. White coat effect will have effect on the blood pressure in the office, but not outside the office. So keep that in mind when you are evaluating patients with high blood pressure. Next, we will embark upon secondary causes of hypertension. There are strong recommendations in adults with hypertension. Screening for specific forms of secondary hypertension is recommended when clinical suspicion is present to increase the rates of detection, diagnosis, and specific targeted therapy. If you have suspicion, just do the lab work to make sure there is no secondary hypertension or find out the cause of secondary hypertension. In adults with resistant hypertension, meaning you have started blood pressure medicine, but it is not responding the way you like to, screening for primary aldosteronism is recommended regardless of whether the hyperkalemia is present to increase the rates of detection, diagnosis, and specific targeted therapy. That's very important. They are kind of strongly come upon identifying primary aldosteronism. Apparently, it is very high. Level 2, class 2 recommendation in adults who have positive screening tests for a form of secondary hypertension, referral to the clinician who has expertise in that form of hypertension is reasonable for diagnostic information and treatment. So I'm going to go one by one. The most common cause of secondary hypertension is obstructive sleep apnea, which is responsible in 25 to 50% of the patients. Clinically, you will have snoring, choking, or history of snoring, choking, gasping during sleep, daytime sleepiness, and they will have a resistant hypertension. Physical examination, you will have obesity, large neck size, meaning more than 17 inches for men, more than 17 inches in women. In the Mallampati class, 3 to 4. Often it causes occlusion when you fall asleep. Loss of normal nocturnal BP fall. Typically, when you are using ambulatory BP measurement, you see nocturnal BP fall, which is abolished in patients with obstructive sleep apnea. And one can use stop bank questionnaire, Berlin questionnaire, or overnight oximetry. How to confirm the diagnosis? Polysomnography, home sleep apnea testing. If no suspicion of non-respiratory sleep, one should look for narcolepsy too. Second is chronic kidney disease, accounts for 14% of secondary causes. Indication for additional testing: diabetes, obstruction, hematuria, urinary frequency and nocturia, urinary incontinence, analgesic abuse, family history of polycystic kidney disease, elevated serum creatinine, abnormal urine analysis. Physical exam might find abdominal mass or large palpable kidneys, such as polycystic kidney disease, skin pallor. Screening test: electrolytes, sodium, potassium, chloride, and bicarbonate, serum creatinine, urine analysis, urine microalbumin, serum cystatin C if it is available, and renal ultrasound. And evaluate the cause of chronic kidney disease. Next is primary aldosteronism, account for 5 to 25%. These patients present as resistant hypertension, hypertension with hypokalemia. It could be spontaneous or diuretic induced. Hypertension and muscle cramps or weakness, hypertension and incidentally discovered adrenal mass, hypertension and obstructive sleep apnea, hypertension in family history of early onset hypertension or stroke. Physical exam might show arrhythmias because of hypokalemia, especially atrial fibrillation. How do you screen them? Electrolytes, including sodium, potassium, plasma aldosterone, renin activity ratio. Confirmation by oral sodium loading test with 24-hour urine aldosterone, or IV saline infusion test with plasma aldosterone at 4 hours of infusion, or captopril suppression test. Adrenal CT scan, adrenal vein sampling. So these are the 3 common causes of secondary hypertension: obstructive sleep apnea, chronic kidney disease, and primary aldosteronism. There's 2 more. Drug and alcohol induced account for 2 to 20%. Sodium containing antacids, antidepressants, nicotine, alcohol, non-steroidal anti-inflammatory drug, oral contraceptives, cyclosporin or tacrolimus, sympathomimetics, decongestants, anorectics, cocaine, amphetamines, and other illicit drugs, neuropsychiatric agents, erythropoiesis stimulating agents, cancer treatment, clonidine withdrawal, herbal agents, mahuang, etc. These patients will have fine tremor, tachycardia, sweating, especially with cocaine, ephedrine, MAO inhibitors, acute abdominal pain with cocaine. Urinary drug screen will show up and response to withdrawal of suspected agent. The next group is renovascular hypertension, account for 0.1 to 5%. Resistant hypertension, hypertension of abrupt onset of worsening, increasingly difficult to control, flash pulmonary edema, especially in atherosclerotic renovascular hypertension, early onset hypertension, especially in women that you see in fibromuscular dysplasia, usually in adolescent girl and above. On exam, you can see abdominal systolic diastolic bruit over other arteries such as carotid and femoral. How do you screen them? Electrolytes, including sodium, potassium chloride, and bicarbonate, renal duplex and Doppler ultrasound, MRA, abdominal CT arteriography. Confirmation, bilateral selective renal arterial angiography. So the common causes are five: obstructive sleep apnea, chronic kidney disease, primary aldosteronism, drug and alcohol induced, and renovascular hypertension. Let's move on to uncommon causes. They are less than 1%. Thyroid disorders such as hypothyroidism and hyperthyroidism both can present or associated with high blood pressure. Hypothyroidism, you will have dry skin, cold intolerance, constipation, hoarseness, and weight gain. Delayed ankle reflex, periorbital edema, coarse skin, cold skin, slow movement, and goiter one can find on examination. Screening, thyroid stimulating hormone and free thyroxine. Hyperthyroidism, they will have warm, moist skin, heat intolerance, nervousness, tremulousness, palpitations, insomnia, weight loss, diarrhea, proximal muscle weakness. On exam, they may have lid lag, fine tremor of the outstretched hands, warm, moist skin, goiter, and thyroid nodule. Screening, TSH, and free thyroxine. Confirmation, radioactive iodine uptake and skin. Other uncommon disorder is pheochromocytoma or paraganglioma, present in less than 0.6%. They present as resistant hypertension, paroxysmal hypertension, or crisis superimposed on sustained hypertension. They can have spells, BP lability, headache, sweating, palpitation, piloerection, positive family history of pheochromocytoma or paraganglioma, adrenal incidental. On physical examination, one can see skin stigma of neurofibromatosis, Kefiel spots, neurofibromas, and orthostatic hypertension. Screening, 24-hour urinary fractionated metanephrine or plasma metanephrine under standard conditions. Confirmation, CT or MRI scan of the abdomen of the pelvis and the gallium dotatate PET CT scan. Other uncommon diseases are aortic coarctation, 0.1%. Young adult with hypertension always suspicious of coarctation of aorta. BP higher in upper extremities and lower in lower extremities. Absent femoral pulses or diminished femoral pulses. Continuous murmur over the patient's back, chest, or abdominal bruit. If the patient was post-operative, you can see left thoracotomy scar. Screening, echo, and confirmation, thoracic and abdominal CT angiogram or MRA. Cushing syndrome accounts for less than 0.1%. These patients will have rapid weight gain, especially with central distribution, proximal muscle weakness, depression, and hyperglycemia. Physical examination, they will have central obesity, moon face, dorsal and supraclavicular fat pads. Wide violaceous triahirsutism. If you examine carefully, you can easily identify Cushing syndrome patients. Screening, overnight 1 milligram dexamethasone suppression test, and definite 24-hour urine-free cortisol excretion, preferably multiple times, midnight salivary cortisol. Oftentimes, you will get an expert opinion from endocrinologists at that point. Primary hyperparathyroidism is very rare. They have hypercalcemia. Screening by serum calcium and confirmatory test by serum parathyroid hormone. Congenital adrenal hyperplasia, even though in adults it's rare, in children, early onset, it is not that uncommon, meaning you should look for when you have a hypertension in smaller kids. Hypertension and hyperkalemia and virilization you see in 11-beta hydroxylase deficiency. Incomplete masculinization in men and primary amenorrhea in women you see in 17-alpha hydroxylase deficiency. So you look for signs of virilization or incomplete masculinization. Hypertension and hyperkalemia with low or normal aldosterone and renin. Or the screening test, the confirmation by 11-beta hydroxylase, elevated DOC, deoxycorticosterone, 11-deoxycortisol, and androgens, 17-alpha hydroxysteroid, decrease androgens and estrogens, but elevated deoxycorticosterone and corticosterone. At this point, again, get the endocrinology consult. Another one is mineralocorticoid excess syndromes other than primary aldosteronism. Early onset hypertension, resistant hypertension, hyperkalemia, they can present as arrhythmia because of hyperkalemia. And low aldosterone and renin, urinary cortisol metabolites, and genetic testing. Acromegaly can present as hypertension. Acral features, enlarged shoe, glove, head size, headache, visual disturbance, diabetes. Physical examination, acral features, large hands and feet, and frontal bossing. Screening by serum growth hormone during oral glucose load, indefinite test, elevated agent, sex-matched IGF-1 level, MRI scan of the pituitary. Let's dive into primary aldosteronism. It's one of the most common cause of secondary hypertension. The high-level recommendation in adults with hypertension, screening for primary aldosteronism is recommended in presence of any of the following conditions to increase the rates of detection, diagnosis, and specific targeted therapy. What are those? Number one, resistant hypertension, regardless of whether hypokalemia is present. When the hypertension is not responsive to regular medications and lifestyle changes, check for primary aldosteronism. Hypokalemia, whether it is spontaneous or induced hypokalemia and hypertension, check for primary aldosteronism. Obstructive sleep apnea, incidentally discovered adrenal mass, family history of early onset hypertension or stroke at young age, meaning less than 40 years of age, and moderate quality evidence. In adults with stage 2 hypertension, screening for primary aldosteronism may be considered to increase. So what they are saying is, across the board, one can check for aldosterone and renin levels. Strong recommendations. In adults with an indication for screening for primary aldosteronism, use of plasma aldosterone. If you suspect aldosterone when you are doing, just use plasma aldosterone renin activity, and the plasma aldosterone to renin activity ratio is recommended during the initial screening. And again, when you are screening for aldosteronism, recommended to continue most antihypertensive medications other than mineralocorticoid receptor antagonists prior to initial screening. So it's recommended to continue the antihypertensive therapy while you are evaluating for primary aldosteronism. That is also was a strong recommendation, class 1 recommendation. In adults with hypertension and positive screening test for primary aldosteronism, continued suspicion for primary aldosteronism based on suppressed plasma renin or disproportionate target organ damage. Referral to hypertension specialist or endocrinologist recommended for further evaluation and treatment. So this primary aldosteronism is represent 5 to 25% of secondary hypertension. So when there is an indication, do it. The indications are here: resistant hypertension with hypokalemia, with obstructive sleep apnea, and incidentally discovered mass. When you do that, when the way you check is plasma aldosterone, renin activity, aldosterone to renin activity, and do not stop antihypertensive medication except the mineralocorticoid receptor antagonist, and refer them to endocrinologist and hypertension specialist. What about renal artery stenosis? The class 1 recommendation is in adult with hypertension and atherosclerotic renal artery stenosis, medical therapy is recommended to reduce kidney and cardiovascular disease morbidity and mortality. So these patients need to be treated aggressively, class 1, and the level of evidence is super A level. The 2A, in adults with hypertension and atherosclerotic renal artery stenosis for whom medical management has failed, that means resistant hypertension, worsening kidney function, or acute heart failure, it's reasonable to refer this patient for revascularization or percutaneous renal artery angioplasty or stent placement. So if the patient is not responding to the medication in atherosclerotic renal artery stenosis, refer them for percutaneous renal artery angioplasty and stent placement. This is a moderate recommendation. In adult with hypertension and non-atherosclerotic renal artery stenosis, such as fibromuscular dysplasia, it is reasonable for revascularization by percutaneous renal artery angioplasty. So in a nutshell, atherosclerotic renal artery stenosis needs to be treated with medical therapy if they are resistant or worsening kidney function or getting to heart failure, need to be remedied by revascularization and stent placement. Third category is obstructive sleep apnea. In adults with hypertension, obstructive sleep apnea who are overweight or obese, weight loss interventions when combined with continuous positive pressure and treatment can be effective in reducing systolic blood pressure. So the cause needs to be identified and treated. That itself reduces systolic blood pressure. In adults with resistant hypertension and moderate to severe obstructive sleep apnea, CPAP treatment can be useful in reducing blood pressure. So how to screen for secondary hypertension? Does the patient have any of the following conditions associated with hypertension, like drug-resistant or induced hypertension, abrupt onset of hypertension, or onset of hypertension less than 30 years, exacerbation of previously high controlled hypertension, disproportionate to the degree of hypertension, disproportionate target organ damage for the degree of hypertension, accelerated or malignant hypertension, onset of diastolic hypertension in older adults, especially when the age is more than 65, unprovoked excessive hypokalemia, insomnia or daytime sleepiness, concomitant adrenal nodule, history of early onset stroke, family history of primary aldosteronism. If it is all there, screen for primary aldosteronism and other forms of hypertension. If they are no, then screening is not needed. When there is a positive screen test, refer the clinician to specific secondary hypertension expertise. If it is not, enhance medical therapy and control the blood pressure. These are the certain medications associated with hypertension one should be aware of. Alcohol. How to manage? The recommendation is abstinence or limit alcohol less than one drink for women, less than 2 drinks for men. Caffeine. Limit caffeine intake to less than 300 milligram per deciliter. Avoid more than 1 cup daily in patients with severe uncontrolled hypertension. Decongestants such as phenylephrine and pseudoephedrine. Use the shortest duration possible. Avoid in severe uncontrolled hypertension. Consider alternate therapies such as nasal saline, intranasal corticosteroids, antihistamines as appropriate. Herbal supplements like ma huang, ephedra, St. John's wort, all needs to be avoided. Black licorice, avoided. Non-steroidal anti-inflammatory drugs and acetaminophen. Avoid systemic non-steroidal anti-inflammatory drug when possible. Limit acetaminophen less than 4 gram per deciliter. Consider alternate analgesics like topical non-steroidal anti-inflammatory drugs depending on the indication risk. Recreational drugs like bath salts, cocaine, methamphetamine discontinue. So three things need to be avoided: herbal, black licorice, and recreational drugs, and limit or avoid alcohol, caffeine, decongestants, and non-steroidal anti-inflammatory drugs. Those are all non-prescription category. It is a prescription category that is whole lot of medication can cause hypertension. Sudden withdrawal of centrally acting sympatholytic drugs such as clonidine and disonidine. Since the clonidine is being used for hypertension as well as for other behavioral disorders, sudden cessation of using can cause hypertension. Stimulants such as amphetamine, methylphenidate, dexmethylphenidate, lisdexamfetamine like Vyvanse, dextramphetamine, all need to be discontinued or decreased in dose. Consider behavioral therapies and non-stimulants such as guanfacine for ADHD. Antidepressants, SNRI, TCAs, and monoamine oxidase inhibitors. Consider alternate agents like SSRI depending on indication. Avoid tyramine containing foods with monoamine oxidase inhibitors. Atypical antipsychotics, risperidone, valnazapine. Discontinue or limit its use. Consider behavior therapy. Recommend lifestyle modification. Consider alternate agents associated with the lower risk for weight gain, diabetes, and dyslipidemia. Immunosuppressants such as cyclosporin. Consider converting to tacrolimus, which may be associated with fewer effects on blood pressure. Oral contraceptives. Use low dose like 20 to 30 microgram ethinyl estradiol agents or progestin-only form of contraception, but consider alternative forms of birth control where appropriate. Avoid use in women with uncontrolled hypertension. So do not use oral contraceptives in patients with uncontrolled hypertension. Systemic corticosteroids, avoid or limit its use. Angiotensin inhibitors and tyrosine kinase inhibitors, avoid or limit when possible. Androgen deprivation therapy such as CYP17 inhibitors or androgen receptor antagonists, avoid or limit its use. So there are medications one should evaluate during the evaluation of hypertension when they are using it, either ask them to limit it or avoid it or use other alternatives. Finally, prevention. As you all know, lifestyle and psychosocial approaches is the first one for hypertension, of course, based on the high blood pressure number. Number one being weight. In adults who have overweight or obesity, weight loss is recommended with the goal of at least 5% of body weight reduction to prevent or treat elevated BP and hypertension. Second is diet and nutrients. In adults with or without hypertension, heart healthy eating patterns such as DASH dieting, dietary approaches to stop hypertension is recommended by National Institutes of Health, United States, recommended to prevent or treat elevated BP and hypertension. I have done blogs and videos that have been given in the message box. Please use it and share it with others. In adults with or without hypertension, reduction in dietary sodium intake, that is less than 2300 per day, moving toward an ideal limit of less than 1500 milligram per deciliter, per day to prevent or treat BP and hypertension. So, dash dieting, sodium, low sodium, and reduction of weight. Another recommendations, 2A recommendation, adults with or without hypertension, potassium-based substitutes can be used to prevent or treat elevated BP and hypertension, particularly in patients in whom salt intake is related mostly to food preparation or flavoring at home, except in presence of CKD or use of drugs that reduce potassium excretion. So don't use if you are having a chronic kidney disease. Other strong recommendation is in adults with elevated BP or hypertension, moderate potassium supplementation, ideally from dietary sources. So the DASH diet is very important to follow, even if you do not have hypertension, that prevent you from developing hypertension. It's a beautiful document created by National Institutes of Health, and that has been awarded as the best diet of 2025 by the regular magazines. It's recommended to prevent or treat elevated BP and hypertension. Of course, one should not give potassium supplement in patients with chronic kidney disease. Alcohol. Adults with or without hypertension who currently consume alcohol should be advised to pursue abstinence or reduce the intake, less than one drink for women, less than two drinks for men. Physical activity. In adults with or without hypertension, increasing physical activity through structured exercise program that includes aerobic exercise and or resistant training is recommended to prevent or treat elevated BP and hypertension. Stress reduction in adults without hypertension, without hypertension, stress reduction through transcendental meditation may be reasonable to prevent or treat elevated BP. And other stress management, one can use breathing control techniques such as yoga may be responsible to prevent or treat elevated blood pressure. Little detail. Weight loss. Aim for sustained reduction in body weight, which is more than 5%. Expect about 1 millimeter of mercury, 1 millimeter of blood pressure reduction for every kilogram reduction in body weight. Second, heart healthy diet. It's a DASH dieting pattern. Consume a diet rich in fruits, vegetables, whole grains, low fat dairy products with a reduced content of saturated or total fat. Reduced sodium intake. Optimal goal is less than 2300. The ideal limit is less than 1500 per day. Reduce dietary sodium intake as described before. Replace cooking or table salt with salt substitute. Potassium chloride, sodium chloride, urinary sodium and potassium. Enhance intake of potassium. Dietary potassium intake decreases the blood pressure, but you have to be very careful. Your hypertension is not associated with chronic kidney disease. Alcohol consumption. Number one, abstinence is the best goal, but if you are drinking, reduce it. Exercise. Aerobic exercise, the recommendation is 90 to 150 minutes walk. 100 to 100, 90 to 150 minutes per week. That will come around like 30 minutes per day, 5 days a week. It reduces or it improves the heart rate reserve 65 to 75%. That's pretty good. Dynamic resistance, 90 to 150 minute walk. 6 exercises, 3 sets, 10 repetitions per set. Isometric exercise, that means kind of resistant exercise, 4 times 2-minute hand grip, 1 minute rest between those exercises. 30% to 40% maximum voluntary contraction, 3 sessions per week. So the resistant exercises 2 to 3 times per week, and others need to be done 7 days a week or 5 days a week. Meditation, slowing respirations as we do in yoga or other transcendental meditation trained by professional, followed by 2 to 20 minutes of sessions that will definitely reduce the blood pressure along with the medications. This concludes the talk on 2025 guidelines, part one. The